Dear colleagues, dear ladies and gentlemen, my name is Egle Ramelyte, and I'm very happy to talk about radiotherapy in disseminated superficial actinic porokeratosis today. I want to thank again for the organizers of this amazing event for Extrail. So thank you very much for having me here and choosing my presentation. First, a quick overview about porokeratosis. Those are a group of uncommon acquired or hereditary dermatoses that occur due to increased proliferation of atypic keratinocytes that show faulty maturation and early apoptosis and dysregulation of differentiation. It is a keratinization disorder whose origin is still not clear. However, there are a few triggering factors that have been defined yet. For example, genetic, ultraviolet radiation, radiotherapy, immunosuppression, drugs or chemicals, or others. Clinically, the porokeratosis present as well circumcised, slightly atrophic papules that can coalesce into bigger lesions, and they usually show a plaque with a keratotic ridge. The middle side can be somewhat flatter. There are more than 5 subtypes of porokeratosis defined, which all show different clinical presentation. However, they all share a histopathological hallmark of cornoid lamella. Here you can see a few examples of different types of porokeratosis. On the left-hand side, you can see a patient with disseminated superficial actinic porokeratosis widespread on the lower and upper legs. The second picture shows a patient with linear porokeratosis, the third one with porokeratosis mibelli, which appears usually on lower legs, and the fourth picture on the right-hand side showing porokeratosis ptucotropica that usually affects genitoanal area. Here you can see a histological figure of a porokeratosis, and what is typical marked with blue arrows is the cornoid lamella. On the with the green yellow labels, you can see the hypertrophic epidermis on the outside of the cornoid lamella and hypertrophic epidermis in the middle of the lamella. You can also see the inflammatory infiltrate on the ridges of the cornoid lamella. Upon closer view, you can see the dyskeratotic and vacuolated keratinocytes over here. This is the cornoid lamella, and some inflammatory infiltration around the blood vessels close to the lamella. The tumor suppressor protein P53 is known to be increased in malignant diseases, and indeed in porokeratosis it is also increased. However, this increase of protein is not related to a gene mutation, which is often seen in malignant diseases. Moreover, P53 is also increased in inflammatory diseases such as psoriasis when compared to healthy skin. And proliferation rate of cells in the porokeratosis is not increased, which all talks to favor of porokeratosis being a rather benign condition. However, malignant transformation was reported in 3 to over 10% of the patients with all types of porokeratosis. However, in psoriasis treated with UV light, be it PUVA or narrowband UVB, we also see development of skin malignancies in 5 to 12%. Porokeratosis are also often associated with actinic keratosis, another premalignant condition. And we can also see keratinocyte atypia in both porokeratosis and premalignant actinic keratosis. However, in actinic keratosis, the risk of malignancy is higher compared to porokeratosis and is about 10 to 20%. However, taken together, increased P53 expression with a low proliferation rate, where data is missing regarding the malignancy or entity of this disease. There are reports that state that large lesions, usually localized on the extremities, may transform into squamous cell carcinoma in the average of 36 years. However, how do we treat the most common type of porokeratosis, namely disseminated superficial actinic porokeratosis, or DSAP for short? It usually appears in quite early patients, young patients, 30 to 40 years old, and mostly on UV exposed areas, that is lower and upper extremities. It can seldom affect face or the back, and it consists of multiple small disseminated plaques with symmetrical distribution, meaning both arms or both legs. It tends to worsen and progress upon UV exposure, be it natural light in summer or narrowband or KUVA for treatment of other skin diseases, and it tends to improve in winter. Patients may not have any symptoms at all. However, up to a third of them complain of itch. But how does disseminated superficial actinic keratosis look in a clinical sense? Here you can see multiple erythematous lesions on the on the lower hand of the patient. And what is important here, we can see it on the sun-exposed side, but not on the less sun-exposed side of the hand. Here we can see the same distribution on the upper leg and also on the lower leg of a patient. However, the backside is somewhat less affected. So how is disseminated porokeratosis treated? A systematic review and a meta-analysis was reported in 2017, and you can see that most of the treatments that were investigated in DSAP were based on case reports, case series, and there's only one prospective multicenter pilot study that evaluated topical diclofenac in patients with DSAP. In this trial, patients received topical diclofenac sodium 3% gel twice daily, and the report said that patients developed partial response by DSAP lesions progressing to a lesser extent on the treated side compared to the global lesion count. However, multiple other treatments that are used for treatment of actinic keratosis, such as imiquimod or 5-FU, as well as laser treatments, phototherapy, have been investigated, and the responses range from no remarkable change to complete clearance, complete remission, and modest effect. So what we did at the University Hospital of Zurich, we reviewed our patients that were treated with Grenz rays for DSAP. We reviewed cases of more than 2,000 of patients, and we selected patients with a histological or clinical diagnosis of DSAP that were treated with radiotherapy and had a follow-up of no less than 4 weeks, and we could identify 8 patients. We evaluated the clinical parameters of DSAP, the concomitant cutaneous pre-malignancies and malignancies, the safety of the radiotherapy, and patient demographics. Here you can see an overview of our 8 patients. You can see that the patient age ranged from 54 was the youngest patients to 84 was the oldest patient. Most of the lesions presented on the legs and arms, and one patient also had some lesions distributed on the back. 7 out of 8 patients had other skin pre-malignancies or malignancies. One patient had melanoma, others had more of keratinocytic disorders such as actinic keratosis, Mervis-Bowen, Bowen's carcinoma, or squamous cell carcinoma. And you can see that all but one patients were pre-treated with all the treatments that I just mentioned being seldomly effective. Here you can see the distribution of the lesions with red color marking the distribution. So least number of patients had DSAP on the upper arms, mostly on the lower arms and lower legs. You can also see the marked other pre-malignancies or malignancies. The most common was actinic keratosis, and you can see an overlap of actinic keratosis and DSAP, and also squamous cell carcinoma labeled with a star, or basal cell carcinoma labeled with a triangle. So those patients received treatment with Grenz rays with 10 kilovolt for 4 gray 8 to 10 times every 3 to 4 days. All patients were able to finish the treatment, in exception with one case which was stopped due to adverse events. And here you can see the total dose that the patient received that ranged from 29 in one case to 52 in another case. Some patients also received soft rays due to other malignancies, for mostly for Bowen's carcinoma that developed on the same site as DSAP. You can see that all patients developed an acute radiodermatitis, but this is also what we expect from patients treated with radiotherapy. And you can see that follow-up ranged from 2 months up to 65 months. Out of 8 treated patients, only 1 showed clinically suspected relapse after 46 months of follow-up. However, none of the other patients showed any relapse in the treated areas. Here I can show you an example of a patient that was treated for DSAP with Grenz radiotherapy. You can see the marked fields on the lower left leg of a patient, and this is already after treatment. You can see that there are only very few lesions left that disappeared later during follow-up, and here we can see we irradiated another site, and here you can also appreciate the post-radiotherapy hyperpigmentation. Another patient had her lesions irradiated on the lower left arm. Again, the known acute radiodermatitis and post-inflammatory hyperpigmentation, which disappeared after a while. You can still see that the not treated areas present with DSAP. However, the treated area is clear of DSAP lesions. And then further case from a patient, we can again see the post-treatment erythema and widespread DSAP lesions. And then after some time, you can see that the hyperpigmentation is fading away. And here is the last picture that we have of this patient. He had all his lesions treated in the meantime. This is really decreasing in redness, and the clinical outcome is very satisfactory. So for conclusion, I would like to say that radiotherapy with Grenz rays could be a good treatment option for patients treated with patients with DSAP. We have a very good known safety profile with radiotherapy, and our results show that the relapses are limited. However, prospective and possibly multiple center studies are needed. Thank you very much for your attention.
Thank you, Dr. Ramelyte. Okay, so first question coming in. What scale are you using to assess dermatitis? I'm not sure what E5 dermatosis means.
Well, thank you for this question. At the University Hospital of Zurich, we established our own radiodermatitis scale, where E1 just is a faint redness, whereas E6 would be necrotic areas. E5 would be very dark erythematous area with hemorrhagic crust. Yes, I hope this answers your question.
Okay, thank you. Next question, why were Grenz rays of 10 kV used rather than 20 kV or 30 kV?
Well, we use this based on the assumption that it's not a malignant disease, also having in mind the histology of the DSAP, which is a superficial lesion, so we don't need to apply 20 kV, which would be soft rays.
Okay, next question. What energy are you using?
You mean in gray? We use 4 to 6 gray, depends a bit on how widespread the lesions are and how fast the patients want to get the treatment done. Our own scale is that we do it 4 gray twice a week. If the patients have to leave earlier for, I don't know, what other medical reasons, then we sometimes do 6 gray at the beginning and then continue 4.
Okay, next question. Do actinic keratosis improve with Grenz rays as well?
Yes, they do. What we also do at University Hospital of Zurich, we treat with radiotherapy larger areas of actinic keratosis, field cancerization, for example, on the scalp area. We also do it with Grenz rays. And yes, they do improve.
Okay, next question. Is there any local treatment for radiodermatitis?
Well, you can use a lot of local therapies, similarly to other wounds. What we use in a lot of patients is black tea compression or gauze. So what you do is you prepare a black tea, a very strong one, and let it cool, and then use a compress on the area that was irradiated for 10 minutes or so, and then apply any other wound healing cream. I don't know what country the question comes from. What we have in Switzerland is Yellogen with hyaluronic acid, or Bepanthen is also very well-known local therapy with panthenol in it. So anything.
Okay, thank you so much, Dr. Ramelyte, for your presentation. It's been a pleasure.